ready to start today. So we are happy to have Felice Gragnano from University of Valgimigli, and he will present a very discussed trial about DPT therapy.
Yeah. I think we can go ahead for some so for some problems. Marco Valgimigli is not with us today, but I think it will be a nice discussion in any case.
Okay, so if you agree, I can share my screen and I can start my presentation.
Sure. Okay, sure. Thank you.
Okay. So, dear friends and colleagues, first let me thank really much the GISA Young Board for their very kind invitation to join this journal club and discuss the recent results of the STOPDAPT-2 ACS trial, which has been recently published in JAMA Cardiology. And a good place to start, I think, is the recent recommendation from the ESC on the management of patients with acute coronary syndromes without a persistent ST segment elevation. And we know that ACS patients with acute coronary syndrome are at high risk of recurrent coronary events related or not to the coronary stents. And in these patients, the guidelines recommend the use of a dual antiplatelet therapy for at least 12 months unless there are specific contraindication or excessive risk in bleeding with a class 1A recommendation. The guidelines also recommend the use of ticagrelor or prasugrel, so potent P2Y12 inhibitor, in preference of clopidogrel, which has lower potency and also high variability in these patients. So the optimal antithrombotic therapy in these patients yet remains debated somehow. And we know that numerous trials have investigated the topic of antithrombotic therapy in PCI or ACS patients. And we can mainly distinguish 5 domains. So trials investigating short versus long DPT followed by aspirin monotherapy, short versus long DPT followed by P2Y12 inhibitor monotherapy, or dual versus triple antithrombotic therapy in patients with an indication for oral anticoagulation, short DPT in patients at high bleeding risk, or antiplatelet therapy in patients with secondary prevention, so in patients with coronary artery disease or patients with peripheral artery disease. And we can say that the STOPDAPT-2 ACS trial can be mainly included in these short versus long DPT studies followed by P2Y12 inhibitor monotherapy. And recently, we performed a large meta-analysis including the entire evidence for the use of a P2Y12 inhibitor monotherapy after a short course of DPT. And as we shown in this meta-analysis, which have been recently published in BMJ, the P2Y12 inhibitor monotherapy studied in 6 trials and more than 24,000 patients was able to reduce the risk of major bleeding with a relative risk reduction of about 50% without an excess in ischemic events. So the therapy was supposed to be safe and effective in these patients. Yet we have to say that this meta-analysis has several caveats. So first, the DAPT was stopped at different time points across trials. So how short can dual antiplatelet therapy be in ACS, so 1 versus 3 months, remains debated. Also, different P2Y12 inhibitors were used in these across trials. And so what should be the P2Y12 inhibitor of choice remains also unclear. And finally, a mixed population of acute and chronic patients were included in this meta-analysis. And so whether or not these results can be applied to an ACS population remain unclear. And these points were addressed by the STOPDAPT-2 ACS trial investigator led by Dr. Watanabe and Professor Kimura from Kyoto University. And the main objective of the trial was to evaluate the safety and efficacy of a short DPT, so 1 to 2 months, followed by clopidogrel monotherapy, as compared with a standard therapy of 12-month DPT with aspirin and clopidogrel in patients undergoing PCI with an everolimus saluting stents after acute coronary syndromes. And here we can see the study design. This was a prospective, multi-center, open label, and investigator-initiated RCT conducted in Japan. And as we can see in this slide, patients with acute coronary syndromes undergoing PCI were screened and then enrolled in the trial. And the key exclusion criteria were use of oral anticoagulation, prior intracranial hemorrhage, and in-hospital complication. So patients with ACS undergoing PCI were randomized to two-arm strategies, and the experimental arms consisted of a short DAPT, so 1 to 2 months DAPT followed by clopidogrel monotherapy. The standard regimen, the control arm, consisted of a DAPT for 12 months. During the early phase after hospital discharge, patients could use both clopidogrel or prasugrel at low dose, but then all patients were on clopidogrel in monotherapy or in combination with aspirin. The primary analysis was set at 1 year follow-up. And these are the study endpoints. So the primary endpoint was a primary endpoint of a net clinical benefit, a composite of ischemic and bleeding events, namely cardiovascular death, MI, definite stent thrombosis, and any stroke, and TIMI, major or minor bleeding. Then the authors also pre-specified two major secondary endpoints, an ischemic endpoint, cardiovascular endpoint of cardiovascular death, MI, definite stent thrombosis, or any stroke, and then bleeding secondary endpoint, defined by TIMI, major or minor bleeding. The study hypothesis, the main study hypothesis, was that the experimental arm, so short DAPT and then clopidogrel monotherapy, was non-inferior to the control arm of standard 12-month DAPT for the primary endpoint at 12 months. The authors predefined a hierarchical testing, so they first test the non-inferiority for the primary endpoint, and then the non-inferiority on the major secondary cardiovascular endpoint, and then the superiority for bleeding, and then the superiority for the primary endpoint. The authors calculated the sample size of 4,000 patients with ACS, assuming a 1-year rate event of 4% that was based on the previous result from the STOPDAPT-2 trial in ACS patients. They also set a non-inferiority margin of 50% based on the hazard ratio scale, based on previous trials, and also consistently with the STOPDAPT-2 trial. And this is the main study flow. As we can see here, we have two main populations that were pooled. The other consider 1,161 patients with ACS from the STOPDAPT-2 trial, and then also enrolled additional 3,000 patients, 3,008 patients in the STOPDAPT-2 ACS trials. And they pooled all these ACS patients in a main population of 4,169 patients that were randomized to short DAPT versus standard DAPT. As we can see here, 33 patients were excluded because withdrew consent. The vast majority of patients were male, so 3,000 patients were male. And as we can see in this flow, the study follow-up was completed in more than 99% of patients. So there was a huge adherence to the study protocol, and also a few patients were lost at follow-up. In this diagram, we can also see the DAPT discontinuation rate. As we can see in the short DAPT group, as much as 96% of patients discontinued or dropped aspirin at 2 months, as recommended by the protocol. So the compliance to the study treatment in both study arms, we can say that was optimal for the trial. Here we can see the main baseline characteristic for the trial. The mean age for the population was about 67 years old. The majority of patients were admitted for STEMI, and this is an important point considering that patients with STEMI are usually underrepresented in other trials for antithrombotic therapy, and they were completely excluded, for example, in Twilight. So more than 50% of patients were admitted with a STEMI. We can also see here that the majority of patients included in the trial were at intermediate or low risk of both thrombotic and bleeding risk. So this is important because only a few proportion of patients were considered at baseline as having a high risk of thrombotic and bleeding events based on both the Credo-Kyoto score but also the Paris score. So only a few proportion of patients had high risk of future events. What is also important to note is that the vast majority of patients, this is a contemporary trial, the vast majority of patients underwent PCI by radial approach. And it is also important to note that the intravascular imaging was used in the totality, almost the totality of patients. So about 98% of patients received IVUS or OCT for guiding PCI. And this is quite different considering what we do today in our cath lab. So there was an extensive use of intravascular imaging in this study. And these are the main results of the study. So for the primary endpoint of net clinical benefit, including cardiovascular death, myocardial infarction, stent thrombosis, stroke, and TIMI major bleeding, as we can see, the rate of the primary endpoint was 3.2% in the short DAPT group and 2.8% in the standard group, such that the hazard ratio was 1.14. And so the experimental strategy was not able to show the non-inferiority. So the study was not able to fail to attest the non-inferiority based on the previous assumption for the non-inferiority margin of 50% on the hazard ratio scale. When we look at the major secondary cardiovascular endpoint of cardiovascular death, MI, stent thrombosis, and stroke, we can see that the numerical risk, the numerical rate of major events was higher in the short DAPT group compared with the standard strategy, with an hazard ratio of 1.50. So there was a numerical increase in the risk of ischemic events in the experimental arm. On the other hand, as was probably expected, we can see that the risk of bleeding, defined as TIMI major or minor bleeding, was reduced in the experimental arm. So almost a 50%, more than a 50% relative reduction in the risk of clinically relevant bleeding in the 1 to 2 months DAPT arm versus the standard group. And in this slide, we can see some individual endpoint at 1 year. As we can see here, there was a numerical increase in the risk of all-cause death in the short DAPT group versus the standard DAPT group. Although we have to say that the difference in cardiovascular death was absent. So we have no difference in cardiovascular death between groups. Regarding the coronary events, we can see that there was a significant increase in the risk of myocardial infarction in the short DAPT group versus the standard group, although when we consider only large MI based on CK-MB values, then we have to say that there was a small difference between groups. Also, the risk of stent thrombosis was higher in the experimental strategy, although the rate of these complications was quite low in both study groups. The number of stroke was also higher in the experimental strategy. And finally, when we look at the major bleeding considered based on the BARC definition, we can see that there was a significant reduction in the risk of major bleeding using a short DAPT versus a standard DAPT. Although when we look at these numbers in terms of absolute rates of bleeding, we have to say that the study populations was not really a high bleeding risk population. We know that high bleeding risk population based on the ARC HBR definition can be defined if we have a 1 year rate of BARC 3.5 bleeding of 4%. Here we have only about 1% of bleeding, major bleeding complications. So this was a low to intermediate risk population for bleeding. At subgroup analysis, there was no significant interaction. And also when we look at the important subgroup of STEMI versus non-STEMI patients, we can see that there was a consistent effect of treatment in respective of the strategy. And finally, in this exploratory analysis, the authors also investigated and stratified patients based on the admission in the STOPDAPT-2 trial or STOPDAPT-2 ACS trials. And it was interesting to see, and also quite difficult to explain why, the data was had a different direction, particularly for ischemic events. As we can see here, the risk of ischemic events was lower with a short DAPT strategy in the ACS patients from the STOPDAPT-2, whereas this risk was almost doubled. So we have a hazard ratio of 2 in the ACS patients enrolled in the STOPDAPT-2 ACS trial. So there was somehow an inconsistency of the data when we look at patients that were enrolled in the 2 different trials. The study has several limitations. First, we have to say that the study was not definite and not conclusive because the non-inferiority was not met for the primary endpoint. In addition, the study can be considered as underpowered because the event rate for the primary endpoints was lower than anticipated and lower than expected based on the 4% rate of events at 1 year that was assumed for the study sample size calculation. Also, this was an open label design, which also carries some limitation. In addition, we have to consider that there are various differences between Japan and US or Europe. So there is difference in the balance between ischemic and bleeding risk. Also, as we have seen, there was an extensive use of intracoronary imaging in Japan, and also standard doses of prasugrel are not used in Japan. We had low dose 3.75 milligram prasugrel in Japan that is not available and currently used or recommended in Europe. Finally, we have to say that there was not an assessment of the chip polymorphism and variation, and we know that there is a high prevalence of clopidogrel resistance in Japanese patients. So this can also have confounded somehow the results. So what are my interpretation of the study results? First, we can say that in patients with ACS undergoing PCI, the results of the study do not support a very short DAPT duration, so 1 to 2 months, followed by clopidogrel monotherapy as compared to the standard therapy. Although major bleeding was significantly reduced with this strategy, there appeared to be a significant increase in adverse ischemic events with a short DAPT, and particularly there was a numerical increase in the overall mortality. So this strategy has to be carefully weighted. What are the potential implications for practice of this study? That while short DAPT followed by P2Y12 inhibitor monotherapy can be considered as an alternative strategy in patients undergoing PCI, in ACS patients without high bleeding risk criteria, the duration of dual antiplatelet therapy should be at least 3 months, and a more potent P2Y12 inhibitor should be preferred over prasugrel. And finally, we know that we need further investigation to establish what constitutes the optimal antithrombotic therapy in patients undergoing PCI, and particularly for ACS. And here I can anticipate that we are currently working to merge and to add additional data to our previous meta-analysis, the Sydney 2, which has been recently published. And we are now pulling data also from this trial, the STOPDAPT-2 ACS trial, and also patients from the master DAPT to add some evidence to current literature. And thank you for your attention.
Thank you very much, Felice. This was a great presentation. I just would like to invite you all to start a discussion. So if anybody has any question, please feel free to ask. Today we were supposed to join by Professor Valgimigli, but who unfortunately had some travels in a cath lab. So I can only say this is our job. So we will go on. So if I can start, I've got a couple of questions for Felice. How do you frame the results of this study in current literature? What do you think should be the optimal strategy for patients with ACS requiring DAPT?
Okay, I think that we have, of course, to carefully interpret these results. The use of clopidogrel after ACS is not the standard in Europe. So I have to say that these results cannot be entirely applied to our current practice. And I think that the optimal strategy in patients with ACS undergoing PCI for antithrombotic therapy should consist of a potent P2Y12 inhibitor. And then we can also consider to drop aspirin, particularly if we have high bleeding risk criteria, elderly patients, CKD, or liver cirrhosis. But I think that it would be probably better to drop aspirin after 3 months or also 1 month, but continuing with a potent P2Y12 inhibitor like ticagrelor or prasugrel. We have to say that this is also not easy, for example, in Italy, because here we do not really have the opportunity to prescribe ticagrelor in monotherapy. And this is something that we also discuss also with the company, because the IFA only found the drug when it is combined with aspirin. So I think that there is a future for the P2Y12 inhibitor monotherapy, and particularly with potent P2Y12 inhibitor, but we have to say that this is still a way to go. There's still something to do with this respect. I think that clopidogrel monotherapy after ACS should not be considered, at least there are specific contraindication or there is a specific setting to consider.
Okay, thank you very much. If anybody has any question.
So, ciao Felice, I'm sorry to everybody for before, but just my computer dead. So one question. I was surprised to see a lot of STEMI patient as well as a large use of intravascular imaging. And my question is actually about eye bleeding risk patient. If you think there is the chance to do this kind of strategy, so perform optimal PCI with the imaging and then maybe a short DAPT, and if there are any sub-analysis of the study ongoing or about particularly the eye bleeding risk patient. Thank you.
Thanks for your question. Yes, I think it was quite surprising but important to see so many patients with STEMI. We know that these patients are usually underrepresented in our trial. They're considered very high thrombotic risk. So when there is a trial dropping aspirin or dropping dual antiplatelet therapy early, it is also difficult also to convince the investigators to enroll so many STEMI patients. But we have to say that this is important because we need evidence also for these patients that were completely excluded, for example, for the twilight. Regarding the use of intravascular imaging, I think that today the use of intravascular imaging and the optimal PCI is a fundamental part of the antithrombotic therapy. We can safely discontinue antithrombotic therapy early, especially in patients with HPR, so at high bleeding risk, only if we are confident that the PCI has been successful, so we have an optimal PCI. If we have an optimal PCI guided by OCT or IVUS, then we should not have really problem with the second generation stent. The stent thrombosis, I think today is really related not to a failure of the drug or the therapy, but to a failure of the procedure. When we have problem on the procedure, then we can have stent thrombosis. This is, I think, more than 90% of cases. And this is also why, for example, in clinical practice, when we see a stent thrombosis, it's also difficult to decide, for example, if we have to switch from prasugrel to clopidogrel, because then you have to think if it was a problem of the drug, but probably it was a problem of the procedure. So I think that really the use of intravascular guidance is critical, is essential today to optimize the procedure. And this is even more important, as you were saying, in HBR patients. In these patients, we have to consider that we can plan to stop DAPT, for example, after 1 month or 3 months, but we have also to consider that the patients can start to bleed even after the PCI during the hospital stay. So we do not know, we know that the patient is at high bleeding risk, but we do not know when the patient will start to bleed. We have a lot of patients that start to have hematuria or also major bleeding during the hospitalization. So if we have an optimal PCI, then we can be somehow confident to say, okay, it's 1 week, it's 2 weeks, the patient has a major bleeding. I can also consider to stop one agent that could be, for example, aspirin, and then continue with a potent P2Y12 inhibitor like ticagrelor. We have data on this from Baber, from published on JACC in a sub-analysis of twilight that show that the potency of the ticagrelor inhibition on platelet was almost the same compared with the DAPT on aspirin. So if we have HBR patients also bleeding, we can safely discontinue one of the 2 agents, and preferably, I would say, aspirin, if we have an optimal PCI in these patients.
Great, thank you.
I have a question, Alessandro, if I can. Thank you, Felice,
yes,
for your presentation. It was a really great presentation, but I'd like to focus on highly variable patients about the Clopidogrel. Do you think that we should benefit for monitoring such therapy in ACS patients? What do you think about this highly variable, and how does it affect, because they are all Japanese people?
Yeah, thank you for your question, Pierluigi. I think that the variance and the polymorphism of CHIP for sure influences somehow the results. So this was a Japanese population. We know the high prevalence of resistance to clopidogrel in these patients. So it was quite surprising. And as far as I know, they are not conducting a sub-analysis dedicated on this in the STOPDAPT-2 ACS trial. This is what Anabe also said at ESC. So they are not investigating this point, which I think is relevant. And today, I think that we have more and more data supporting de-escalation therapy, supporting guided therapy to optimize the antithrombotic strategy and to reduce the risk of bleeding and optimize the ischemic efficacy, the anti-ischemic efficacy. Yes, I have also to say that I'm not sure that we will see in clinical practice soon this strategy, because we know that clinical practice have to be fast and simple. And we really know that sometimes it's really difficult to add some strategy, also diagnostic strategy, and to risk stratify patients. We know that we never use clinical risk score. We never calculate precise DAPT because it took 10 seconds. Then it is easy to think that we will use in all ACS patients or in all PCI patients additional techniques to make the strategy more precise. I think this would be useful, but probably, at least for now, this would be only for selected patients. So I think this is really interesting, and they are publishing a lot of data on this, and I think this is the future. But I think this will remain only for selected patients and not for the totality of patients undergoing PCI.
Thank you.
Thank you very much. I think we got time for just the last question, if anybody has something to ask.
Good morning. I just have a question about the paper. First of all, very compliments for your presentation, very clear. The rate of complete revascularization, there were a lot, the revascularization of the patient were complete, because I cannot understand the higher rate of MI compared to the no differences between stent thrombosis in these patients. And also, I would like to know, what do you think about the extension of the outcome over 1 year of the over 1 year, because all those studies stops at 1 year follow-up. But in a low-risk patient, we should low risk, low bleeding risk patient. We just have to look at more time of endpoint. What do you think?
Thank you very much for your questions. First, the revascularization were complete, and the authors recommended to enroll patients after the also stage procedure were done. So they had a complete revascularization, and what they used in the primary endpoint and also as a major secondary endpoint were definite stent thrombosis. And so what we have seen in the data are definite stent thrombosis, whereas usually the trial tried to use as a secondary endpoint definite or probable stent thrombosis, as we know. So that probably was the reason for this difference between MI and stent thrombosis. Regarding the other point for the extension of the follow-up, the study is intended to study patients up to 5 years follow-up, and it will essentially evaluate the monotherapy, so not a dual antiplatelet therapy in these patients. I think that we have to carefully select the long-term antithrombotic strategy is really a moving target today. We have to really focus on the ischemic risk. If a patient has tolerated well the therapy, we can consider to continue with the ticagrelor low dose or with clopidogrel. But in addition to the use, to the distinction of a dual or a single antiplatelet therapy, I think that is defined what should be the best antithrombotic strategy in case of monotherapy. We have a lot of data that suggests that clopidogrel, for example, could be better for ischemic prevention than aspirin. So I think that we have really to investigate further, and we are really now conducting a meta-analysis on this also with Marco to compare aspirin versus clopidogrel monotherapy in patients after 1 year and on monotherapy. Of course, if we have patients that did not bleed and did not have any problem with dual antiplatelet therapy, they are at high bleeding, high ischemic risk, they had complex PCI. I think that probably among the ischemic risk factor, the most important are the presentation, so the initial presentation, for example, STEMI presentation, but more importantly, probably is the complex PCI. If we have patients with left main, particularly in bifurcation with 2 stents, many stents on their coronary, then I would really say that this is a patient that could continue dual antiplatelet therapy also after 1 year. All the other clinical factors that should guide our decision, like age or CKD, for example, they are both influencing the bleeding and thrombotics risk. So I think that probably the major driver for continuing dual antiplatelet therapy after 1 year should be procedural data and complex PCA data. This is my feeling.
Okay, perfect. Thank you very much, Felice. This was a great discussion. Thank you very much to all of you. I think we are finished, and we will come back in the next week with mitral clip failure. So see you the next week. Thank you very much.
Bye, guys.
Bye-bye.
Thank you. Ciao, ciao.